Thank you everyone for being here. I appreciate it. My name's Allysa. I will be presenting on our MASLD and MetALD MASLD MASH Community Network presentation tonight. Let me just hide things from myself. Hide meeting controls, hide that. Okay, so let's get started. So we will be discussing MASLD and MetALD tonight. Like I said, my name is Allysa Saggese. I'm a nurse practitioner at Cornell Medicine in New York. I work in hepatology and research. And if you'd like to record your attendance, you can use this QR code now to do so. I know I think you have to register on the way in too, but I think this is still needed to record attendance. Okay. So we're going to start with a case with our patient, Ashley. So she's 52. She came to us for an evaluation of an ultrasound that showed a little bit big of a liver and some increased echogenicity that's interpreted as fat in the liver. But otherwise, she really feels well. She has no complaints. So here is her medical history and some other factors. She has PCOS, hypertension, hyperlipidemia. We did learn that she has about 2 glasses of wine a day. We did a physical exam. Her liver feels okay, not tender. And she takes some expected medications, amlodipine, atorvastatin, a multivitamin, and milk thistle. Milk thistle makes me think she might have already known about this fatty liver, but it's neither here nor there in this. So for her vitals, her blood pressure is a little high. I do wonder if she took her medicine before her visit with us. But otherwise, the heart rate is fine. Her BMI is a little bit above normal. We do see those elevated liver tests. According to ASLD guidelines, normal for a female should be about 25 or less for ALT and AST. So both of those are a bit above normal. Not crazy, just not normal. Billy is on the edge there of being abnormal. Her platelets are fine. A1C is prediabetes and triglycerides are elevated. We did a fiber scan, so we get a kPa of 11.4 and a CAP of 310. So that kPa would make me a little bit worried that we might be finding some advanced fibrosis with this patient. The CAP score confirms what the ultrasound showed, which is fat in the liver. So here is a reminder if you went to the prior talks about the spectrum of steatotic liver disease. All the way on the left, we have our straight, as I call it, straight MASLD MASH, meaning fatty liver without anything influencing it, solely the cardiometabolic factors and fat in the liver from that. MASLD is the more common finding, and MASH is a little less common. It is the inflammatory type. We have MASLD with increased alcohol intake. And we have a sliding scale there of more if it's MASLD predominant or alcohol liver disease predominant based on the amount a person is having, their average intake in grams of alcohol. Then we have more to the right, alcohol, liver disease, and other rare causes. So we're going to be talking about that sliding scale in the middle there. And this is available easily online to find if you want. So one thing that many patients may not have any idea about is what a standard drink looks like and if they're having that or something more. So some places have pictures to show, some people explain it, and you try to get a history on a patient and it can be difficult to really pin down an ounce amount. I don't know many who would actually be totally clear on how many ounces of a beverage that they've had, but the visual can help. So these are all different examples of a standard drink here in America and the amount of liquid in that cup. And just for information, a standard drink of alcohol, I looked it up, is 0.6 ounces of pure alcohol, which is 14 grams. So it is very hard to start talking about all of this and, you're barely estimating properly with the patient, let alone being able to convert it to grams. But it is one standard drink should be about 14 grams of alcohol. So every time we talk about grams here, just try to remember that, as I will too. So there is multifactorial problems happening when we have a MASLD MetALD patient. So we have the MASLD risk factors. These all say NAFLD because the study where this was from came before the name change in 2023, probably on the cusp, but it says NAFLD here and we mean MASLD. So we have our risk factors for MASLD, which are all of the cardiometabolic factors on the left: insulin, diabetes, unhealthy, sedentary, etc. In addition to that, having some excessive alcohol intake, meaning in this case, not zero, and maybe some on the scale of more than recommended per day, it causes multiple things to happen in the liver. So we have oxidative stress, we have impaired lipid handling, we can disrupt the intestinal microbiome, but I think some people might realize that as they feel it the next day, that their microbiome is upset. And then, of course, we get inflammatory responses because alcohol is a toxin, as is fat to the liver. So if you think of it that way, you're insulting the liver with two different kinds of toxins. And so together, they accelerate this disease progression and can cause fibrosis faster than MASLD alone. So this lovely diagram is mostly to show the risks of decompensation by the disease of SLD. The middle is the MetALD, to the left is MASLD, to the right is ALD. What I would take from this is that MASLD alone with advanced fibrosis has a 5-year, 5 to 15% risk of decompensation, whereas those with MetALD, that's almost doubled. Not almost, I'm sorry, that is doubled. And ALD has a wider range of 5-year risk of decompensation. So while patients, the nomenclature change was important because we're not now calling it non-alcoholic. We're not using the word alcohol in the name. And it perhaps is good and bad. It doesn't necessarily elicit the same response with patients, like I don't drink, and therefore it's non-alcoholic. Alcohol doesn't have anything to do with it. But it is important to distinguish, one versus the other, and that there can be a mix. And so calling it MASLD MASH identifies the cardiometabolic parts of it, and the MetALD and the ALD, we can explain more clearly what the cause of the liver problem is. So this helps us broach that subject of, well, with just, MASLD, the risk is a little lower than it is when you've had alcohol in the picture with it too, at a rate higher than we would recommend. In addition to that, the cardiometabolic risk factors themselves can put someone into a higher risk of decompensation, or at least complicates the picture, even if it may not change their risk. Their genetic risks increase all of the possibilities of MASLD for them, makes them more prone, the PNPLA3, etc., can make someone more prone to MASLD MASH, and therefore an alcohol consumption would compound that. And then, of course, at the bottom, the alcohol use, it increases by the amount of grams, as we've been discussing. Okay, so this slide is to have a really nice visual about fatty liver, but also what we can do to discuss alcohol use and how we can detect it. So that's, on the left-hand side is more of our discussion about the progression of steatosis and to steatohepatitis, the role of alcohol and diet and other factors. When we're discussing this with patients and we're talking about alcohol consumption, it can be a very tricky subject, as I'm sure everyone knows. It is great to have very objective measures to be able to use. And so those can be a questionnaire or taking some sort of sample of body item like blood, urine, or hair. And that can be a way to screen for alcohol consumption. And you already may have their history, and so you can add in that metabolic characterization. And so for results, these are actually coming from that study at the bottom there. that in about 20, in their MASLD and NAFLD patients, they've had a percentage that actually did have moderate to excessive alcohol consumption. So in that population, there was about 25%, and that probably can be applied to our population too. So just as fatty liver, MASLD, it affects about 30% of the world, and of those, about 25% may get the inflammatory MASH, the progressive type. Well, of our MASLD patients, maybe another 30% or 25% or so is actually a MetALD patient instead. That study by Stouffer et al., they determined the optimal diagnostic would be a hair ethylgluconoride urine and an audit C altogether to determine if your patient does have MetALD with a maybe moderate to excessive alcohol consumption. However, I'm going to tell you, I'm not collecting hair for my patients, and a urine ethylgluconoride is not going to determine alcohol consumption over many, many days or months. It's going to do it within a certain amount of hours time, maybe 72 max. So you would have to be doing this in a well-timed way to be able to have good results, or be, snipping hair and taking those kinds of samples. I find blood tests to be the easiest, and questionnaires are easy too, but they may not be something we have time or feel like we have time to do in clinic. And therefore, I think we rely pretty heavily on blood tests, being the PEth test, which comes up in this diagram. So here's a new kind of way to think about our breakdown of steatotic liver disease specific to MASLD, MASH, and MetALD, our way to narrow it down to determine the diagnosis. And alcohol liver disease is on this as well. So we would have evidence of metabolic dysfunction because with MASLD, we diagnose it by having at least one of the cardiometabolic factors in the presence of obesity, or two cardiometabolic factors without obesity with evidence of steatosis on imaging or FibroScan. So we have high BMI, high glucose, all the things you'd think about when I say metabolic, high cholesterol, high blood pressure. One determinant that you can think about specifically is, do they have an isolated high blood pressure or an isolated hypertriglyceridemia? So do they have high triglycerides? Yes. Have you checked about their alcohol use? Alcohol can raise triglycerides. If you have not yet checked, or if they are not disclosing, consider PEth testing. I think that these will box. Okay. So PEth, if it's available, I do really like this test. I feel very comfortable being able to at least start or continue the conversation about alcohol use with a very objective number. It allows me to broach the subject in a much more objective way. Can't quite tell me that your blood tests are 0 when I can see it in front of us and we can talk about it. And also, it's not going to necessarily be accusatory of me believing or not believing. It's just what it is, and we'd like to see it go down if it's above normal. So there is another box or two. So if you're assessing alcohol use, you should try your best to quantify it in some way, but drinking patterns can help. The history, have they ever had any trouble with alcohol? You have some of those audit C questions. Do you need an eye opener? Has anyone ever told you need to cut back on drinking? You don't maybe have to, what's the word? Sorry, I lost my word there. You don't necessarily have to print out and hand them a questionnaire. If you know the questions too, you can talk through it. Sometimes it might be easier for someone to answer on paper so they don't feel like, some sort of way by answering the question verbally. Either way, you get into some of those and you can get some idea for the person. And so if PEth is above normal, as it's showing their alcohol use in grams per week, with a PEth result of, for MetALD, it would be moderate drinking, 25 to 200. PEth higher than 200 is excessive use and a very high PEth, and that's more leaning towards alcohol-related liver disease. So with our patient, we got a PEth, and it was 120. So it hits that middle ground, that moderate. too heavy, because if it's about 200, that's the heavier side. And so we do need to talk about her about 2 glasses of wine a night. Honestly, I'm going to go back a little bit. If you think about it, when you look at this glass of wine, this picture makes it look like it's half full. If you had an actual true wine glass, 5 ounces is the bottom of the glass for a lot of glasses, especially those red wine glasses that are shaped in a certain way. So this in and of itself might not actually help you because this isn't real life. You know, some places even have glasses with like a gluey type substance in it to make it more permanent, and that's a real good visual, having the actual thing in front of you to show them, this is 5 ounces. Do you pour higher than this? So this person could be having 2 5-ounce glasses, which is still more than is recommended for women in America. Or she could be pouring more than that and calling it 2 because it's 2 literal glasses, but it's not actually a standard drink. So there's a differentiation too. Asking about how much in the glass, more so than how many glasses. So if a person's willing to give this information, you can get a lot of knowledge from it and understand and be able to talk it through reasonably, but you may not even get that far. So just things to think about and potentially aim for if you can. Okay, so a PEth, I liked the description of saying it's kind of like an A1C of alcohol. So that urine gluconoride that I was referring to is only showing alcohol in the urine as it's being excreted. And it's not in the urine for as long as things are in the body and in the blood. So our urine test can be negative after a few days, even if there is high alcohol use, just because of the timing. Whereas a PEth, this particular study showed that after 1 binge episode for a group of healthy people, the PEth was still detectable for up to 12 days after. So that tells us that a high day of drinking, it'll still be detectable. These metabolic toxins from alcohol will still be detectable for more than a week after that event. And this also, the mean back. Yes, that's right. So this is the back over hours from the time of the binge, but the PEth itself can extend, it's a chart would extend longer than this. So person who's having an alcohol intake daily or nearly daily will sustain their levels, and you will get that back in a PEth to be able to understand about how much alcohol toxin is rolling around in their blood. I usually talk about it like that too. I say this test measures how much breakdown of alcohol and what toxic metabolites are in your blood from alcohol. And if the number is high, I usually approach it saying, whatever you're doing is too much for your body because your body still has all of this it's breaking down. Now, of course, this can be influenced by timing a little bit. So you do take that into consideration. But so in general, then, if you happen to PEth them really close to a binge, and that's it for them, that was going to be it, the bachelorette party, something crazy, it should go down over time and it should stay down and 0 if that's truly it for them. So while you may have some skewed result based on timing a little bit, it should also match what they're telling you. And this study also showed there was no significant variability by sex and BMI, which is also reassuring that we don't have to take those into consideration. We're getting pretty accurate results no matter who we're testing. Okay, and this particular study was looking at those who have excessive weight and have alcohol use, who may be at risk for MetALD. So they did their, this is how those graphs usually go. They explained what they looked for, who they enrolled, whoever they took out, and how many they were left with, and what numbers they were looking for. So in the end, out of 333 patients, about 97 had suspected MetALD, which is about 15%. So if we go prior to the prior studies that we're mentioning, about 25, 28% have risk for MetALD as well, or likely MetALD, it's not a non-zero number, and that's really not an insignificant number. So again, it emphasizes the need to screen and to be as accurate as we can with history if they can be forthcoming, since I know this is a touchy subject for a lot of people. It's hard to broach. So now we're going to talk about the effect of her medical history, alcohol use in these settings. So with alcohol and hypertension, there have been many randomized controlled trials. Alcohol is shown to have a biphasic effect on blood pressure. It decreases blood pressure for some time after consumption, but then raises it in some hours after consumption. So if you think back, our patient had an elevated blood pressure. She's also diagnosed with high blood pressure. I wonder what it would be like if she cut out alcohol entirely. She is taking a blood pressure medicine, but we don't quite know, actually now if we know this, we don't quite know where her blood pressure truly stands without alcohol in her body. Because if she's having alcohol every night and it's more than she should have, then 13 hours later when she's at her next appointment the next morning, her blood pressure is going to be high. And perhaps every time she's gone to a doctor, her blood pressure was high. So some more things to think about. And this chart explains a lot of their outcomes from the study. But that's the basics, is that things go down at first and then come right back up. And so with triglycerides, they increased over time with drinking alcohol. And so it is another thing to think about, where when we're measuring how long ago did the patient last have some alcohol and how much are they affecting these results? And do you treat what you're seeing, or do you try to also change things to see if that helps those results that you're concerned about? So more pretty graphs with all of the results of these studies. Okay, so we're back to our patient, and this is a review of all the things that we just discussed about her and all of the lab results and our elastography and history. So at this point, we're going to be giving our recommendations as to our assessment and what to do for the patient, the plan of care. And our diagnosis, of course. Sorry, I was presumptuous, and we already knew kind of what her diagnosis would be based on the title of this talk. But she has MASLD with predominant MetALD. MASLD predominant MetALD. So she has MetALD with MASLD predominance. So what do we treat? We're going to talk about the basics of MASLD MASH treatment, which is good diet, exercise, weight management. She can be a candidate for resmetirom because there is no particular recommendation about alcohol use in resmetirom. However, we have a particular recommendation, which is she should stop. I also will emphasize this to patients with advanced fibrosis. Alcohol can muddy the picture for a lot of things, as we were just discussing, blood pressure, triglycerides. It can make just inflammation in the liver. Her ALT was not over 100, so that FibroScan was technically an accurate test. But if her liver's unhappy and it's stiffer and more inflamed, then that FibroScan might be elevated. So it has affected a lot of things, and therefore it's what we're basing our treatment on. However, if we stop alcohol, we need to reassess because things might get better. It might get a lot better even. So she is a candidate for resmetirom as she stands, but perhaps stopping alcohol might be enough to maybe make her no longer a candidate. Perhaps the combination, she might need both. It isn't something I would wait on if it's advanced fibrosis, but perhaps someone with a little bit lesser of a level, it's a discussion to have how much it can actually be influencing everything that we're discussing. And so our recommendation is to stop. And I always tell patients, no amount of alcohol is safe. Our recommendation is none is best. And does she need HCC screening? Is yes, because she had that advanced fibrosis on FibroScan. So our basics for MASLD and our basics for alcohol use in liver disease. I think we can all remember that. So the ideal MetALD definition for clinical trials would be based on objective biomarkers. It would help us not have to rely on a patient's recollection or their reporting to us, since that has so many ways it could be incorrect. To find a standardized assessment of recent alcohol use, it sounds like PEth is pretty common, but perhaps there will be an even better way soon. and to find a way to certify alcohol abstinence, which would be this assessment of recent alcohol use if we had one that was a very standard and available test. So we would also want to make sure that the drivers of liver disease are present for clinical trials in order to understand how the drug that is being tested would affect MASLD MASH. And a lot of trials do include patient has to have at least one cardiometabolic risk factor. And after alcohol use, that would help define if the patient definitely has hypertension or hyperlipidemia, which is what I was saying. Perhaps this person has had all these numbers and the medicines on because the alcohol has driven her numbers up every time she's been tested. And so in a clinical trial, we would just want to make sure that they have met all this criteria for a standard amount of time in order to make sure that the trial is not influenced by some other factor. So all of this would be most ideal for clinical trials, which are how we get our medicines. So if we can do this for a trial, then we'd be able to implement it in practice in some ways in order to standardize things across the board. So nearing the end, our take-home messages. Oh, and I'm hitting time. Sorry about that. Our take-home messages are knowing this new definition of MetALD, which is an alcohol intake beyond 140 to 350 grams, 210 to 420 for women and men respectively. And that 140 is 10 standard drinks a week. So remember, if she's filling up the alcohol more than 5 ounces, then that's already 2 drinks in there. And 10 wouldn't be that hard to get to if you're having 1 or 2 of those every night. And that can same for men with the way they might pour things. That clinical criteria can underestimate MetALD, especially if we're not testing properly and assessing in a most objective way we can, like a PEth, and reassessing our metabolic dysfunction over time. As I keep saying, if they stop all alcohol use and things change, then their metabolic factors change, and that's a good thing for them. Or is it persistent and now that is the predominant liver driver? And we do need to make sure that we consider adequate exposure to risk factors and that our criteria for clinical research should help us facilitate objective MetALD diagnosis, allowing comparisons among groups and or better assessed liver medications that are coming down the pipeline so we understand how it's affecting MASLD alone and MetALD. Okay, so very last thing is this QR code. I think this was the right QR code, Christine. I know you told me there was one. This one. Okay,
yeah.
Got it. Yeah, okay. I didn't go that far when I was looking. So
yeah, we have a few QR codes.
Okay. So if you need that one, this is to get to the website. And then if you can, we would like you to complete a short survey on the presentation today to help further improve and give us feedback.